welcome everyone. Thank you for joining today's webinar on clinical issues in medical respite care. I'm super excited because we have Courtney Podson, who's our Director of Clinical and Quality Improvement here at the Council, presenting today on chronic conditions in medical respite. We also invite you to introduce yourselves in the chat, who you are, where you're from, and at Courtney's prompting, some things that you might have been enjoying this summer, hopefully in not a post-COVID world, we're not there yet, but in a post-vaccination world. So some things that you've been able to enjoy. So I will turn it over to Courtney in a minute. I just do want to share that the recording from today's webinar, as well as the recording from last week's webinar on activities of daily living, are available on the registration page. So I put that link in the chat here. So within about a week, we'll have the recording from today posted there, as well as the publication of the clinical guidelines that go along with today's presentation. So with that, I'm going to turn it over to Courtney. Thank you so much, Courtney, for leading us through this conversation.
Thanks, Caitlin. It's wonderful to be with you all today. I am always happy to talk about medical respite. One of the things that I knew going into today, we would be a mixed group of clinicians, social workers, OT, staff, folks that work in and around respite. So I don't want you to think that we're just going to do deep dive into medical conditions. We're more going to think about the structures and how to incorporate some basic structures to provide chronic disease management within your recuperative care program. And as always, I'm going to go back and forth between respite and recuperative care. Apologies, that's just how it goes. All right. We're going to start going over the objectives. So we're hoping by the end of this, you'll be able to identify common chronic conditions in people experiencing homelessness, the impact of homelessness on chronic conditions, and identify the potential role that medical respite and recuperative care can have in the treatment and management of chronic conditions, and that you'll be able to identify strategies to address chronic conditions within the medical respite setting. So just to start a definition, this is a definition from the CDC, that chronic diseases are defined broadly as conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living, or both. That is a huge umbrella. We are by no means going to address the expansive world of all chronic diseases and conditions. But this is, I think, important to realize that when we are having folks within our respite programs, that there are a myriad of issues that they're going to present with. They will have probably their primary acute diagnosis, the thing that they're coming to the program for, direct support for. Though there will be many other conditions that they need additional support on, or other conditions that they've never gotten treated or diagnosed. And so when we think of how do we provide holistic care, we have to include chronic conditions within this model. I also wanted to say that I know I have trusty friends that are going to be monitoring the chat, but if there are things, Caitlin, that pop up that I don't see right away, if there are questions from the group, please come off mute and ask. I'm happy to field questions as we go. So please ask questions along the way, and then I'm hoping to leave time. I'm keeping track of time so we have room for conversation at the end as well. All right, so I wanted to start with this smaller list, slightly more manageable, of some very common chronic conditions. I really did a tongue twister with this presentation. All right, diabetes. Diabetes is a disease in which the body's ability to produce or respond to the hormone insulin is impaired. So this results in abnormal metabolism of carbohydrates and elevated levels of glucose in the blood and urine. Diabetes is very common in our population, and it is one of the most difficult to manage. It is so difficult because it is highly influenced by our environmental conditions. The ability to take medication is really complex. The medication regimens are complex. It is impacted by our ability to access healthy foods, our nutrition education and background. So there's many social determinants of health that impact diabetes. So this makes it very difficult to treat and to manage while people are experiencing homelessness. COPD is a chronic progressive inflammatory lung disease that causes obstruction, airflow from the lungs. It's characterized by breathing difficulty and wheezing, and really just chronic shortness of breath. Their classic sign of COPD, though, is that it is a progressive illness. This is something that you go through periods of exacerbation, and then your lung function decreases, exacerbation and decreases. This is not something, the goal is really stabilization. There is no cure. And so for folks that with COPD, it's really important to get this well managed so they don't continue to lose lung function, and over time they can become dependent on oxygen. It's also another one that's really significantly impacted by environmental and social conditions. And so if we have folks that live in a place where there's tons of wildfires and they're sleeping outdoors, the smoke is going to exacerbate their COPD. You are living in extreme temperatures of hot or cold that exacerbate COPD. Folks are smoking, all of these other conditions in which people live and choices that they make impact the COPD. Heart disease is a disease that affects the heart. Coronary arteries disease is the most common, and it puts you at higher risk for heart attacks and strokes. Again, dietary choices, lifestyle, lack of exercise, stress, all impacts heart disease. And HIV, human immunodeficiency virus, is a virus that attacks the body's immune system that over time decreases your body's ability to fight infections. And then cancer is not one we often think of in chronic conditions, but if we go back to that definition of lasting more than a year, many folks live, by the time that they are diagnosed, treated, and in long-term either remission or treatment or progression of the cancer is beyond a year. So often we may be having folks that come into respite programs that, for example, if someone had breast cancer, they may have had a mastectomy, they may have had chemoradiation, but they might be on long-term tamoxifen. They might be taking a oral medication long-term, but they have been missing their surveillance. They haven't had a PET scan, they haven't had mammograms, they haven't had their follow-up care. So this is something we have to also think about in terms of chronic conditions within respite programs. And again, it is an opportunity to make sure we're providing that holistic care and while they're in our programs. So as I mentioned with those conditions, causes of chronic medical conditions, there are causal, but also things that exacerbate chronic conditions. And those are the social determinants of health. So those are some social, environmental, genetic combination of things. There are things that just by growing up in an environment where you live closer to the highway puts you at high risk because of fumes, that puts you at high risk for things like asthma that goes on to cause COPD. Family history, genetics might predispose you, but then you also might live in an area, so you might have a family history of diabetes, but then you also might live in a food desert. And the only place you can access food is a corner store. So you have a high carb diet, you don't have access to fresh fruits and vegetables. So all of these things that are combinations of social, environmental, genetic, lifestyle choices combine to cause chronic conditions. When we think of the impact of homelessness on chronic conditions as causal and things that exacerbate, they often fit into many of these because accessing healthy foods is really challenging. Occupational hazards, people might be not have much choice when it comes to occupations, so they might be taking higher risk jobs. Lack of physical activity, may not have access or the ability to exercise in a safe environment. All of these different things each of these different components can be exacerbated by homelessness. So these are situational pieces that can also exacerbate chronic conditions. So there are genetic, social, environmental, and then there's also situational. So in the place that you are living, what is the access to healthy foods? What is your ability to store or access medication and supplies? So even if you're in a Medicaid expansion versus a non-Medicaid expansion state, that is a situation, that's just the state that you live in. That is you can live in one state versus another and have access to one insurance, but in be no different situations. So that's just very specifically situational. Lack of access to culturally appropriate care. You may be someone who is an immigrant. You do not speak English. You may not be receiving any of your education of your chronic illness in the language that you primarily speak. This is a huge barrier. If you aren't familiar with the local fruits and vegetables, how can you properly prepare something? And if we're telling you this is the diet you need to have and you're not familiar with those vegetables or fruits, what are you supposed to do? It's just really difficult. So part of what we need to be doing is making sure that what our education we have is actually meeting people where they are, and it's going to be something that's meeting them appropriately. Lack of transportation is always a huge barrier for folks, just to be able to access care, medications, just basic get to work, and lack of consistent place to sleep. This is just so critical for just being allowing your body to rest and to heal. And then these are all self-explanatory: lack of shower and laundry services. So I wanted to talk a little bit about limitations in addressing chronic conditions. So often what happens in a medical provider's office is that someone sees a PCP and they are given a medication for a condition. The challenge is when we do not ask questions around social determinants of health, and we don't, as a medical provider, ask the situation which people are living in, we can prescribe medications that become really difficult for patients to tolerate taking. When someone doesn't have regular access to a bathroom and I'm prescribing a diuretic, which makes someone have to urinate, not just a lot, but with high urgency, that they're not going to take it. And they might have congestive heart failure and need to take diuretic. So this is incredibly important. We have to make sure that we're coming up with plans that are actually meeting the situation in which people are living. All of these other medications might cause urinary frequency or retention. Medications causing constipation and diarrhea, again, without access to a bathroom, that is incredibly challenging. Cost is a huge barrier, being uninsured, but also underinsured. I know folks frequently can't afford medications because of the copays. So that's when working with a local pharmacy, and often not retail pharmacies like CVS or Walgreens, but sometimes your local smaller pharmacies will work with you to waive copays for certain patients. So I encourage you to build relationships with your local pharmacies. And then complications and regimens. We're going to get into this, but the more medications someone has, the less likely they are to take them, which is really difficult because that usually means that they have multiple chronic health conditions and they need those medicines, but there is a direct inverse relation to the more frequent or the higher amount, the less likely they are to take them. And then often when without a consistent place to store medications, folks' meds get stolen. That happens all the time. Backpacks get stolen. People hear pill bottles. They get swiped because the hope that they might be something valuable, but often they're just hypertension or diabetic medication. So that is a common problem. So yeah. All right. So part of what is important when we're thinking of the impact of chronic conditions is the physical symptoms that folks are experiencing and how difficult this is when it's combined in someone who is experiencing homelessness. So impaired mobility, many conditions from stroke, which might cause unilateral weakness, to arthritis that causes significant joint pain, can cause significant gait disturbance. If you have a limp, if you need an assist device like a cane or a walker, we have a gentleman who he has such severe ataxic gait and he uses a cane, and the tip of his cane he goes through in a week because the rubber gets worn so intensely. And so part of our casework intervention is the caseworker always has to make sure that they're ordering a steady state, a steady supply of the rubber stopper for the cane. If he doesn't have that cane, he's essentially immobile. So it's incredibly important that when we are thinking about the impact of chronic conditions after someone is being discharged from medical respite, we have to make sure that we're looking holistically at their mobility and their ability to function at a shelter or in the next place they're going to be sleeping. I can't overstate the impact of neuropathy. So many of our patients, whether it's from diabetes, liver disease, injury, impairment, there's so many things that cause neuropathy, and it goes on to cause really intense discomfort but it also often causes decreased sensation, which puts people at higher risk for wounds. And if you're feeling pins and needles and you don't feel an open wound on the bottom of your foot, and you're sleeping in those shoes day in and day out, and you're walking on your feet all day, it's a recipe for a wound disaster. So really, really important to make sure that we're assessing and treating for neuropathy. Shortness of breath. This is really something that is from COPD to coronary artery disease. I mean, there's so many things that cause shortness of breath and decreased exertional capacity. And so if you're thinking of someone that has a hard time walking at one city block, what is the realistic expectation that they're going to be able to be discharged and just, go out into the world and be able to completely function? We have to make sure that we're having comprehensive plans around, are we making sure we've signed them up for transportation assistance, door-to-door transport, the paratransport. So making sure we're thinking of holistic physical symptoms when we're coming up with this discharge plan. Chronic pain, this is a big challenge in respite. Many folks experiencing homelessness have chronic pain for a multitude of reasons. Delayed treatment and diagnosis, to just under treatment of pain because of stigma, especially when folks have a history of opioid use disorder. They're just very likely to be denied or turned away from any pain control. So really encourage you to have partnerships with chronic pain clinics that treat pain holistically. This is another important aspect of care. And then finally, cognitive impairment. I know this is near and dear to Caitlin's heart because it impacts such a large percentage of people experiencing homelessness. We cannot have education interventions and support folks in their transition if we're not identifying that people have cognitive impairment. We're not coming up with treatment plans accordingly. So it's really important that we're understanding disease processes that cause cognitive impairment and identifying when people have, if we are concerned, important to get the assessment to properly diagnose folks within our programs. Also just wanted to state that the research is profound around impact of chronic conditions and the impact on emotional well-being. There are significantly higher rates of depression and illness-related anxiety and stress. And if you're adding onto someone experiencing homelessness, diagnosis of a heart attack, I mean, it's just so overwhelming. It just feels like, how can I get out of this cycle? And the depression actually further exacerbates the coronary artery disease. So there can be a negative causal cycle there. You can feel a sense of hopelessness, exacerbate social isolation, especially if you're having a lot of those other symptoms that I mentioned. It's difficult to feel connected when you're having difficulty and you're having, you're limping and you're feeling really short of breath. That can further isolate you. And then I also just want to mention that chronic conditions may alter their appearance and contributing to impaired sense of self. So having a stroke and not being able to use part of your face, or having slurred speech from that stroke, or having a really significant gait on top of experiencing homelessness, it brings a lot of shame to people, and it further makes them not want to engage. It makes it just a much higher barrier. So it's really important to make sure that we are actively addressing and providing emotional support for folks as they are working through some of their recovery through these chronic conditions. This is where support groups can be profoundly impactful. And in respite, creating that sense of community, having that community shared space, weekly touch-ins, just things that bring people joy, because, when they're out of that program in the next shelter, they might not know anyone, and that be further isolating. So trying to create the sense of community within respite is also incredibly helpful. So I wanted to just talk a little bit about the long-term impact of chronic conditions for people experiencing homelessness. So part of the challenge is that even at the beginning step here of diagnosis, for people experiencing homelessness, there's often a delay. So part of that is increased barriers to care, decreased access to health care. To get a diagnosis, especially something like COPD or coronary artery disease, you often need advanced testing, pulmonary function test, or MRI and other echocardiogram and other tests for diagnoses. And that's just a higher barrier to care, because you have to see a provider, you have to get a referral, you have to go to the hospital to get those tests. And we see this often in cancer diagnosis. We end up seeing folks in late stage 4 cancer by the time they're actually diagnosed. And that's because a delay in screening, they're not being screened for routine cancer, not receiving the routine screening for cancer care. And then this is just leading to a delayed diagnosis until someone actually has a lump or a deformity, and then, or they end up in the hospital because they're so ill from it, and then we get the diagnosis really late. So just want to point out that the diagnosis is often the first step, but for people experiencing homelessness, it's often just much more delayed than the general population. And then lack of access to treatment exacerbates illness. So if we take COPD and then lack of access to treatment, then again, we start in that cycle of exacerbation. And that's where people can get stuck in going back and forth from the hospital to the community because they're not getting appropriate care, they're not on the appropriate medication. And because they're in this exacerbation cycle, they end up with a high symptom burden. So just shortness of breath all the time, having a hard time walking more than a city block, that goes on to cause disability. And then this is a really difficult cycle to get out of because then you start to get depressed. It's overwhelming. It feels like, well, I can't even control this. How could I get out of homelessness? How could I get back to work? You start to have complications from the chronic condition, the compounding impact of social determinants of health. And then if you don't treat that heart condition well, it puts you at high risk for a stroke. And then it puts you at risk for early death. So this is a really depressing, overwhelming slide, but it's an important one to say that this is a really intense cycle. So part of the importance of medical respite and addressing chronic condition is that we can really work upstream here. We can work on that diagnosis while they're in. We can get that imaging done while they're at the recuperative care program. We can stabilize that chronic condition that was sending them back and forth to the hospital. We can stabilize them on their medication, all while they're here for that acute wound. But while they're getting that treatment for that wound, we can get them on the inhalers for their COPD, and we can stabilize their insulin regimen for their diabetes. So it really, if you think expansively, we can really work on addressing chronic conditions while they have this really amazing time, while they're a captive audience, while they're there for all this additional wraparound services and support. We can really work to stabilize their chronic medical conditions and prevent that early death. So we just want to talk a little bit about comparing the difference. So we have acute issues of chronic disease, and then we have chronic disease management. So the acute issue of chronic disease focus on the stabilization of the acute process. So, and really to stop or decrease the immediate suffering. So examples of this are hyperglycemia. So you have someone who is a diabetic, they are insulin dependent, they may have run out of all their medications, and they're cycling back into forth to the hospital. They might be in the ICU, and then they get back out to the community. They don't have their insulin, they don't have insurance, and they're right back in the hospital. This person, we can stop that cycle by getting them to respite. It is an acute issue, so they're there for the diabetes. They're really there for the education, the support, the medication management. But then we have the chronic disease management parts. And so even if that's the same diagnosis, we can then also do the nutrition education, the multidisciplinary team. We can work on a lot of other pieces, but likely they don't only have diabetes. They also will have hypertension, COPD as well. And when we're working on the chronic disease management, we can ask and explore, what are the patient's goals? How can we work on the symptom management? Because likely they're not feeling well. So how do we really highlight the entire interventions to their symptom management and then long-term goal setting and habit formation? And part of it is decreasing suffering and meeting their needs and identifying their goals. And as a medical provider, I always want to work on preventing end organ damage. That's going to help us not have beyond 15 different medicines and have multi-system organ failure. So we want to make sure that we're aligning our goals, but it's always going to be patient driven. So this slide I almost always include because I think it's really important to talk about how homelessness exacerbates chronic health conditions, but health conditions can exacerbate and cause homelessness. So I know many of my patients through an acute medical condition like a heart attack lost their job. And that may have been what preceded the domino effect of them losing their housing and becoming homeless. And then being homeless continues to cause difficulty in managing that chronic illness. And in that process became really overwhelmed and depressed and really started to struggle. And that exacerbated maybe a history of a substance use disorder. And maybe they started to drink. And this is just one example. There are many others, but these are so interdependent, and really the housing is such a key point at stabilizing this vicious cycle. And I just wanted to add on both sides that stigma, lack of opportunity for connection and engagement exacerbates the mental health components here, because if someone's disabled or they're struggling with a health condition and they're in the community experiencing homelessness, they feel so much shame and stigma in that. And then often there's so much social isolation, which really exacerbates the mental health component. And then on the health side, the lack of access to health-sustaining resources like medicine and consistent nutrition exacerbate the chronic health conditions. So these, again, these social environmental components add and compound to these challenges. So this is an old slide. So the language isn't great because we want person-first language always, but I did think it was really, really important to highlight these percentages. So if we look at folks who are experiencing homelessness versus those who are housed, the burden of illness is profound in people experiencing homelessness. So you see rates of diabetes are twice that in the homeless population, hypertension again about twice that, HIV 20 times, that is unreal. Hep C profoundly elevated, and then depression and substance use disorder just gets exponentially higher. So this is really important when we're thinking of when we provide holistic services, we have to make sure that we're including chronic disease management, mental health conditions, and substance use disorders, because the burden is so high on people experiencing homelessness. So in your recuperative care program, have that topic admitting diagnosis, and then make sure we have either partnerships or internal resources to address these other components. We need to make sure that we're treating folks holistically and providing care for all of these diagnoses, whether that's internal in your program or external. So this is important to highlight for folks that are unsheltered versus sheltered. So not only is it housed versus people experiencing homelessness, but there is even a further disparity in folks that are in a shelter versus those who are sleeping outdoors. We saw that the point in time count before the pandemic showed that there are more people sleeping outdoors than ever before. So you know the rate of unsheltered homelessness is skyrocketing. And then we see this impact on health, physical conditions. We look at physical health, mental health, and substance use related loss of housing for sheltered and unsheltered adults. The percentages for folks is wild. The burden of the trimorbid conditions, the physical, mental health, and substance use are so profoundly higher in folks that are unsheltered and sleeping outdoors. And then we look at unsheltered and sheltered adults who are experiencing trauma. So for all, we see a huge difference, unsheltered and sheltered, but especially in women. So this is really profoundly important when we're thinking about treating the disease burden is very high, and then the trauma burden. So when these folks are coming into our program, again, thinking holistically, we want to provide wraparound services for their physical, mental health, and substance use challenges, but also knowing that they're coming with a really high burden of trauma. And so we have to make sure that we're providing care in a trauma-informed manner, and knowing that we're building services that are going to meet the needs of those that are struggling the most. So if we can build a program that is trauma-informed and meeting the needs of those who have the most burden of trauma, then we're going to be able to have a wide net to support everybody. This is really, really important that we're considering those that are struggling the most and are the most marginalized. Women who are unsheltered, who are struggling with all three components. All right. All right. So I want to ask the question. So this is challenging. Are chronic conditions in medical respite a barrier or an opportunity? So we have competing needs here. So we, depending upon our funding model within the program, we might be getting funding from the hospital, who wants to make sure that there's a place for a patient to get discharged to. But then there's pressure on that hospital to get you the next patient and the next patient. So you can't keep them for months and months, right? So that's a challenge in terms of timing. How can we provide this holistic wraparound services within 7 days, right? Whatever the insurance company or whoever the payer is, that is a challenge. Also, do you have the adequate facilities and staffing to support chronic health management? Do you have folks that can do the education, that can actually do the assessments to make sure that they have the cognitive abilities to be able to do what we're asking them to do. The admission criteria specific to immediate post-acute needs or being open to admission to prevent exacerbations of chronic illness. And by that, we mean maybe someone has cycled back and forth to the ER 10 times for their hyperglycemia, but they don't need inpatient care. Would we take someone like that, that maybe they're not actually inpatient, but maybe we could stabilize their conditions so not in that cycle? Is there a health equity need or gap in your community? Can we take steps to address this within our setting? So there's a lot of questions to ask, and I think the funding streams complicate this a little bit in the time within our program. But the hope is that we are providing holistic services and being able to provide and meet people's emotional, physical, and substance use needs within the program. Finding that balance between the admitting diagnosis and managing all their chronic health conditions is a challenging one. We know it. We admit it. We're not saying that this is easy to do. For people experiencing homelessness, this likely means a complicated combination of mental health, chronic medical conditions, and substance use disorder, which require a multidisciplinary team. There is not a one-size-fits-all approach here. But respite programs really do provide an amazing opportunity to support patient medication management, which can benefit all conditions. If we're doing the education around their medications, if we're simplifying their medication regimen and nurses taking the time to sit with them, explain to them, creating charts, that's going to benefit all their chronic health conditions, not just one. So there really is a multitude of benefits within this. Again, a great time to simplify medication regimens. Going to come back to that idea that the more we prescribe, the less they take. So really good time to try to stabilize their conditions on the medicines within respite. And I also want to highlight this is a great opportunity to establish specialty care and catch up on wellness. What better time to do a fit test than while they're in recuperative care? So you could check that colon cancer screening box for a year, catch them up on a PAP. They won't need another one for 5 years. Get that mammogram while they're going to the hospital for their other imaging. Their screening rates for cancer within this population are so low. So we can use recuperative care as a way to vaccinate people, screen for cancer, and really move from just late diagnosis to getting them caught up on their wellness. So it's a really wonderful opportunity to meet them in that need. All right, so we're gonna go talk a little bit about approaches to chronic medical conditions within recuperative care and some strategies. So again, just wanted to bring up the idea of this burden of trauma in this population. So trauma-informed care is intentional awareness in response to both current and historical trauma and understanding that there is a neurobiological impact. So people experiencing homelessness have a higher burden of adverse childhood experiences. And if we look at the top right, where it says, for people who have had 4 or more adverse childhood experiences, and again, I know many of you know this, but ACEs, that grouping is a combination of abuse, neglect, or household dysfunction as a child. And if someone has experienced 4 or more, they're 3 times more likely to have lung disease. They are 14 times more likely to have commit suicide, 4.5 times more likely to develop depression, 11 times more likely to use IV drugs, 4 times as likely to have been begun intercourse at 15, and 2 times the level of liver disease. So there are significant neurobiological choices or impacts that trauma has that go into impacting people's choices and then their responses to situations. And so it's really important to make sure that we're designing programs with this in mind, understanding the impact of this trauma over the lifespan. These are some of the components of trauma-informed care, and we could spend a whole day training on trauma-informed care, but just really wanted to go over some of the real basics when you're thinking of chronic disease management. So to start, I think what's really important is talk about the right to self-determination. Medication is a choice. If someone has diabetes and they don't want to take medicine, that's their body. They're an adult. They can choose that. They will, unfortunately, probably experience some really intense symptoms, and they could get to the point where they end up in the hospital, but it's still their choice. And I know as medical providers and medical team, that is an uncomfortable place to sit. But part of our job is to be subject matter experts, provide our recommendations, provide options, try to move obstacles out of people's way, bring in resources. But our job is not to tell them what to do. Our job is to not cause further trauma and harm, and to partner with them and collaborate with them and with mutuality and respect. And so part of that is coming up with creating suggestions around medication ideas and plans, and then asking them what they want. What are their goals? And sometimes it is to take as little medicine as possible. And then sometimes I say, well, if you only want to take 2, here are the 2 I would recommend. And we start from there. And sometimes they are okay and they feel okay taking them. So maybe later they might take 2 more. But it's really driven by them. And so it's really important that we're keeping that in mind. I think safety, again, this is uncomfortable but important to say. I want people to make informed decisions for themselves. And so if someone who has diabetes is not going to take their insulin, I want them to know what the impact. I'm not there to scare them. I'm just there to tell them I'm concerned because this will cause neuropathy, which could be really uncomfortable. It also could cause you to be in the hospital because your sugars get too high. But my real concern long-term is this is going to cause kidney damage and kidney failure, and I don't want you to experience that. And so part of it is just sharing your concern, what's short-term, what's long-term, and letting them make the decision what's best for them. And that really helps to shift the power dynamics, right? This is not patriarchal. We're not here to tell them what to do. Our hope is to build trust and that they keep coming back, and that over time we'll continue to support them in their journey, whatever that may be. But again, it's their choice. Team approach. Respite is best done as a team because not one person can do it all. And this is just one example of one team with a primary care provider or a provider within the program, a nurse, medical assistant. You might have a peer support, social worker, case manager, and then adjunctive team members too, who could be in the program. You partner with the program, you might refer. So just want to talk about, just share how valuable it is to have a team-based approach in this setting. The role of providers, I just wanted to, I put ally first for nurses and medical providers in the same way, just to highlight that trauma-informed care approach. So we're there to support them in their goals. And so first, we want to start with being allies and creating a space of compassion. And the nursing role is really powerful within respite. So much education can happen. Nurses are like special sauce in respite. I think you need really wonderful nurses in respite to have a great program. Providers are there to assess, diagnose, offer treatment, but also I think one thing that is really important is information gatherer. You can get so much more information within respite than you can in a 15-minute appointment. We get to observe them. We get to observe them over time, over hours, days, weeks. And so that can be really profound, saying, oh, they can administer their insulin. I didn't realize that. They never shared that with me. So there's also a really profound time just to come up with realistic treatment plans. And I think lastly, for providers to identify and advocate for the best level of care in short and long term. So part of that is saying, actually identifying and diagnosing someone's cognitive impairment, actually understanding what their functional needs are like. Are they actually able to meet their ADLs? And then assessing, do we need to start the process for assisted living? Is that the client's goal first? But understanding, is this person safe to be discharged? Do they need a higher level of care? And what other resources can we gather to be able to make this a smooth transition? Case management is so essential for addressing social determinants of health and really trying to break down the steps to start small and for an iterative process, and like gathering resources, applying for housing, all those pieces. But then I also just wanted to highlight the role of a peer. We can't overstate the power of having a peer, someone with lived expertise on your team. That really helps to bridge the healthcare team and just someone that can really share the journey. And then again, behavioral health is so important in terms of being able to provide that holistic wraparound services to be able to meet folks where they are in their mental health and substance use treatment needs. All right, we're going to try to barrel through a little bit, okay? Approach for assessing needs of history and questions. One of the things I wanted to share is that Again, this is a really unique time for information gathering. We have some time with this person. Do great medical reconciliations. Have them get all their bags of bottles of medicine and actually figure out what they're taking and who's prescribing what. Comprehensive intake and history. This might be an iterative process. That person might be really overwhelmed if you try to sit down with them for an hour and get their entire medical history. So it's okay. We want to be comprehensive, but this also should be patient-driven and patient-led. That's part of the trauma-informed care approach, right? Physical exam, again, a time to actually do a comprehensive physical. It's difficult within a 15-minute appointment, but when you have time, you can do it as an iterative process. But I encourage you, please take people's shoes off and look at their feet. It can tell you a lot. Folks walk a lot of miles in those shoes. They sleep in them. They don't get a chance to take their socks off. So often for folks with chronic medical conditions, a foot exam can tell you a lot. So please go there. And then wellness, again, like I mentioned, this is a great opportunity to get folks caught up on their wellness. Assessing needs. I put a lot of resources here just so you have access to them, but depending upon the level of your program, depending upon your needs, I do encourage you within your program to always ask folks around their substance use disorders upon arrival, because we want to prevent withdrawal. We want to prevent folks from becoming uncomfortable unnecessarily. And part of that is we just want to ensure that folks' needs get met and really trying to create a space of non-judgment and harm reduction, and just saying, I just want to make sure that you're getting your needs met. I don't want you to suffer unnecessarily. Asking really detailed questions around their substance use history to make sure that they're getting access to treatment if needed. And then we have seen, fortunately, a surge of managed alcohol programs during the pandemic. Our partners out of San Francisco have done a great job at the Sobering Center. And so they have been using the alcohol withdrawal assessment, the Situa scale. There are other programs that we, fortunately in Canada, that have been doing managed alcohol programs and are leading the way in this effort. And it's really trying to prevent the high levels of alcohol use from the sedation and prevent the low levels of alcohol use from dangerous withdrawal. And so when I spoke to Alice from Sobering Center, she said, they saw really profound impacts, and they saw people that were finally able to stabilize their health, stabilize their drinking, and decrease their drinking safely, rather than going through that cycle of binge drinking, being really intoxicated, self-detox or withdrawal, trying to get their needs met, getting alcohol, and then starting that cycle over and over. So that is one way we've seen medical respite meet those needs, meeting the needs of those that are struggling with alcohol use disorder. So more to come on that. Fall risk assessment, this is always good to make sure we're highlighting those that could be a fall risk. We don't want people to be further injured within our programs. I helped to start and run a medical respite program for women. Incontinence is a prolific issue. And I know that Caitlin just spoke about this, but it is, there's some information here that you can ask folks to start addressing that need as well. And then just some others here. I won't go into each of them, but they all are helpful in different ways. Just want to talk a little bit about individual routines. Again, really focusing on being patient-driven and patient-led in the goals when they're coming in for admission into your program. I will say one of the things I thought was really helpful from the beginning of it, from admission to discharge, is really clear expectations of what, why they're coming to the program. Oh, that's next week. Thank you. I thought it was last week. I forgot. ADLs. But clear expectations, I think anticipatory guidance is so important, letting folks know how long to plan, they can be in the program, what will we expect of them to stay in the program, rules, guidance, especially depending if you're shelter-based or freestanding, it can be really different. And so it's important to have very clear expectations for the client. I also just want to say that motivational interview, a piece about motivational interviewing. Medication adherence is really hard for everybody, even if you're like housed and have resources and language isn't a barrier and you can read. So for folks that have a lot of barriers, it's very challenging. So roll with it. And I think part of it is just using a harm reduction approach. Where do you want to start? What are your goals for your chronic disease management? And then stay curious. Let yourself just be like, what is this person? What are their needs? And you might over time figure out what the barriers are. but it will take time. All right, just want to highlight major predictors of poor adherence, and there's a profound amount of research around here. Treatment of asymptomatic disease. So if you're trying to treat hypertension and people don't feel anything with their hypertension, they say, well, what the heck why am I taking this medicine? If you're prescribing medicine with a ton of side effects, no one wants to take it if they don't feel well. And lack of belief and benefit from treatment. So this is where it's really important to partner with the patient and do really good education. I tell my patients all the time, if there are too many medications out there for you to take something you don't like. So if you don't like a side effect, tell me. And we're going to continue to partner and work on this until we find something you like. Again, frequency of dosing is inversely related to adherence. So once a day, look at that adherence, up around 80%. 4 times a day, we're down to 50. So often for folks who have chronic medical conditions, we're prescribing multiple medicines multiple times a day. So that continues to be a huge challenge. So simplify your regimens as much as possible. Non-clinical strategies to improve adherence is placing stickers on pill bottles, color coding them, coming up with pill box. Blister packing medicine is a lifesaver. Work with a pharmacy that does blister packing. I don't have one in Maine. It is so frustrating. I did in DC. There's an amazing resource if you can find a pharmacy that can do it. All right, I'm going to skip over this one. So I just want to talk a little bit about just giving an example of once daily regimens for diabetes. These medications are often expensive when we think of SGLT2s, DPP4 combination medications. But I have found when I call my Medicaid office and say, this person has been admitted 10 times for hyperglycemia and they're having a really hard time with their medication regimen, they will approve a prior authorization for this patient. This is challenging. Diabetes in particular, taking insulin 4 times a day and add pill burden. So these are just some examples of how we can, if someone is really struggling with insulin, we can really maximize oral medications once a day to get that A1C reduction down. So as you can see, this combination would be a total reduction of 5. So we could get that person down to a 7, maybe if we're really lucky. Not saying this is easy, I just wanted to give you an example. So this is just another example of other ways that you can get some reduction down. I also want to talk about Trulicity for a minute. GLP-1s are lifesavers. Once a week injectable medications that help specifically with postprandial blood sugars, a huge win. I have a lot of patients that I get on oral medications and then I get them either to come into clinic or we start it while they're in respite. It takes a few weeks until you see the impact, but Trulicity is a game changer. That way they don't have to do the daily insulin. It's not in place of, it's not an insulin, but it can really help if someone really does not have the ability to self-administer insulin, they might be able to come to the clinic once a week for that medication. So here's an oral medication plus a combination with a once a week injectable. So just wanted to give some concrete examples to simplify regimens. Some other considerations around HIV medication. I just first and foremost want to say when someone's diagnosed with HIV, when their CD4 count is over 500, 400, they have time. You know, this is not an emergency where they need to start medicine. And the idea of taking medicine for the rest of your life when you're 20 something is really overwhelming. So part of it is just saying like, take some time. We'll think about it. We can monitor your CD4 count. And again, just being really client driven rather than the expectation you have to start this medicine right away. There are ways in which we can safely support clients to make a decision for themselves for when they're ready, because we want them to be able to take it every day rather than take it and then stop and then have resistance. So it is important for folks to really buy into treatment. And then considering access to meals, a lot of medications need 400 calories with the medication. And so we want to work with infectious disease doctors to come up with regimens that are possible and effective. Cancer care and respite, again, just wanted to talk about how you could have someone with an acute diagnosis, but then we also have the ability to provide chronic management in terms of catching people up on surveillance, disability, maybe needing to apply for disability, and assessing ADLs or need for hospice care. So recuperative care can help really with both. Again, COPD can help, respite can help with both in the acute and chronic phase. And again, because the chronic relapsing illness component of COPD, palliative care might be appropriate. Hospice is for people that are within 6 months of death, but palliative care is really for chronic illnesses where there is no cure. So palliative care could be a really meaningful partner as well. All right, so standards for medical respite. This is for quality accommodations. I just wanted to give a shout out to the standards. You can always access those. There's a really wonderful in-depth guide around all the medical standards, but just wanted to highlight a few to setting up the environment. So I know that when I'm in my home, I mean, my providers don't walk into my space or my bedroom. And so I think it's really helpful for clients to know what's their space and then what's the clinical space where staff will be and where they're not. So then they can have a sense of safety. And again, that's part of the trauma-informed care piece of just allowing folks to have some space in which they can feel comfortable when they're not a patient per se. So that's just also a helpful component. You want to always make sure that it's ADA accessible. My program in DC, the elevator kept breaking down. That was a huge challenge. We want to make sure that we have a space that is accessible for folks with varying abilities. And then important to integrate shelter staff into respite team. If you are a shelter-based program, it's essential. We need to be able to make sure that we're working together and not we're not dueling. All right, we're running out of time. So I wanted to just go through this quickly and then open it up for conversation. So the approach for diet, my big takeaway here, and this is a challenge. This is often debated. We want people to have medically appropriate diets, but if they don't have that medically appropriate diet outside of respite, and I'm treating their medications, titrating them to this medically appropriate diet, and then they leave and they only have access to a high sodium diet, that might not help them. So we want to make sure that we're creating realistic treatment plans and plans supporting clients and understanding how to make healthy choices within the options available to them. All right. And harm reduction approach is good always across the board. So to diet, to medication, and to disease management. All right, so the rest of these slides will be available, but I know we are running out of time, so I just want to open it up. I'm going to stop sharing my screen to see if folks have questions.
Please feel free to jump in with questions or put them in the chat and we can read them out loud for folks too.
So I know that that was fast and we covered a lot of details, but just would love to hear if folks are having any particular challenges when providing care for folks with chronic conditions within their programs or strategies that you found that you want to share that's been really helpful.
While you're contemplating questions, I've also been going to put a link in the chat for the survey. If you would please complete that for today's session as well. We do look at them and they are really helpful for us in developing future content. So.
Hi, I just jumped on. I'm so sorry. Can you guys hear me?
Mm-hmm. Yes. Yeah.
I'm Jen Sinarsky. I do a couple of recoups in Los Angeles, and I'm running the quarantine and isolation unit for LA County right now. And I just wanted to say hi. I don't know if you guys have like a group where everybody's asking questions of one another, but I'd love to be a part of that, be helpful in any way I can. Because I'm sort of actually new to recoup, but I've been working with the homeless for a while. At any rate, yeah, you probably have already said all that and I missed it, but I just thought I should say hi. So thank you for doing this. This is great. Yeah, and I have a couple of nurse practitioners that I would love to also include next time.
Awesome.
Well, the great part, Jennifer, is that we can, these conversations are being recorded and you can share as well. And there is such a great wealth of information on our website, but feel free to reach out to any of our staff. We're happy to talk further and support your teams as much as we're able. I see a question in the chat about how can we more concretely do more prevention, like the example of combination of prevention and care in terms of resource promotion or harm reduction. It's a great question. I think a lot of prevention, when we're doing health education, it encompasses a really wide breadth and depth of conditions. And so if you're doing education around diabetes and you're talking about health nutrition, I mean, that's going to impact cardiac conditions, you know, and other chronic disease, HIV and other things. So just by providing that education within your programs is all in and of itself preventative in terms of medication management and diet. I think the harm reduction piece is a big one. I think in terms of just being able to connect folks to care long-term. And so I think that's part of the discharge planning, is making sure that hopefully they'll be connected to a primary care while they're in respite, and then making sure that they have a place that they can connect to afterward to be able to build off of the really great work that was started while they were in the program. Have we fund or finance resources for prevention programs? Do you mean in terms of like smoking prevention, substance use treatment? I'm curious what in terms, are you thinking of something in particular around prevention?
I wonder too if it's kind of like you mentioned at the beginning, Courtney, that, you know, if our major offenders are hospitals, right, and paying for a bed for access to an acute condition, how do we fund beds to maybe take folks in who are referred from a health center or a street medicine team with some of these more chronic issues? It may be related to that too, which is really tricky. I don't know if we have an answer for that. Julia could jump in as well, but I think that is something to think about with your programs and where funding opportunities might be. I don't know if you want to add more, Courtney.
Yeah, I think part of what we're hoping to do long term is to make sure that this is a Medicaid reimbursable service, right? And that we're diversifying funding streams, because the hospital is really only caring about, I mean, hopefully they care about the person, but they want to decrease the length of stay within their hospital. They're not motivated to care about their chronic conditions long term, but Medicaid as a payer or other managed care organizations would, because they want the stabilization to decrease costs for that person long term. And so we are hoping, you know, part of our work and policy and advocacy work is trying to work with state Medicaid systems to eventually come up with a more sustainable funding model for respite. So we're working on it. Yeah, so there are some great programs that are starting to incorporate or fund social determinants of health. And we're starting to see some good return on investment for housing. It makes a big impact in stabilizing people's health conditions. But there are things like paratransport that Medicaid and Medicare cover. We know that we've seen great some pilot programs for fruit and vegetable prescription programs that some MCOs and Medicaid programs pay. So there are some, but they're state by state, MCO by MCO. So that's part of the challenge. They have not been standardized across the country, but we have seen the tide has been turning, and we have seen good research and data come out around investing, having Medicaid and Medicare invest in actually addressing social determinants of health.
So we are at our time, so we don't want to hold folks longer. Thank you so much for joining our webinar today. I hope that we see many of you all next week. We are tackling incontinence and incontinence management, another hot topic with not easy answers. So hope you'll come and join that conversation. All of our resources will be posted to the website. Please complete the survey. And if you have any questions, of course, reach out to the National Council and National Institute for Medical Respite Care. We're happy to get you connected with resources. So thank you very much, everyone, for joining us today. And thank you, Courtney, for this excellent presentation.
My pleasure. Thanks, everyone.